Morning, my name is Damien Collison. I'm a consultant cardiologist at the Golden Jubilee National Hospital in Glasgow, and I'm discussing the results of our randomized controlled trial, Target-FFR, which examined a physiology-guided optimization strategy after stenting. Well, yes, we did notice that certainly the proportion of patients with FFR less than 0.80 was substantially higher than some of the early registry data in the area, and also that the proportion of optimal post-PCI FFR greater than or equal to 0.90 was lower. That said, there are some more recent publications, a smaller study from last year from Azzolini and colleagues, which reported a similar proportion of about 34% in their study of patients with optimal post-PCI. And more recently, earlier this year, Barry Uretsky and colleagues had published a similarly sized study, I think over 200 patients with final FFR less than 0.8 of up to 36%, so even higher than our own. And I think as a group that has a lot of experience in post-PCI FFR measurements, it was reassuring to see they were finding similar proportions. So the rationale for this study was that we had identified there was significant uncertainty in the current literature as to what the real incidence of optimal and suboptimal post-PCI FFR values among patients were. And we recognized that obviously there have been proven associations between better outcomes with higher post-PCI FFR results. So accordingly, we designed the study to, I suppose, provide some of the first randomized data in this area and to establish the incidence of these outcomes in our own practice here in Glasgow. So the study was an investigator-initiated trial. It was a single centre. That centre was the Golden Jubilee National Hospital in Glasgow, which is a quaternary cardiac referral centre for Scotland and is currently the highest volume PCI centre in the UK, performing approximately 3,000 PCIs per year. So the design of the study is a randomised controlled trial. What we did was had quite an open inclusion criteria. We wanted to capture and include as many patients undergoing routine standard of care PCI with us here as we could. So our inclusion criteria were quite broad. Exclusion criteria were primarily just about safety concerns for patients and also removing I suppose categories of physiological uncertainty, such as bypass grafts or acute microcirculatory dysfunction, as you could have with very recent STEMIs, etc. So beyond that, we kept the inclusion criteria as open as possible. So what we did was between February 2018 and November 2019, we randomized 260 patients in the trial. And all patients received blinded post-PCI coronary physiology assessments. And our two groups then were a blinded control group, at which stage after their blinded post-PCI measurements, the procedure was deemed complete. And then we had our intervention arm, which was labeled our PIAS arm. PIAS, our abbreviation, stood for Physiologically Guided Incremental Optimization Strategy. And the goal here was that if amongst that randomization group, we identified suboptimal post-PCI FFR, i.e. less than 0.90, we would apply our protocol guided optimization measures to see if we could improve on the proportion of patients with optimal results. Key results from the study were the primary outcome was defined as the proportion of patients with post-PCI FFR greater than or equal to 0.90, which has previously been suggested as the optimal level. So the primary outcome, we established that there was a 10% difference in favor of the PIAS intervention in terms of that optimal proportion. However, it didn't achieve statistical significance. Now, the largest, probably the most likely explanation for that is actually the power of the study. Ultimately, while 131 patients were randomized to receive the PIAS intervention, in the end, only 40 actually received optimization measures. So still a reasonable improvement for given the amount of patients that received it. Now, our key secondary outcome, however, was the proportion of patients with a truly suboptimal post-PCI FFR result less than or equal to 0.80. Now, in that category, the PIAS intervention was able to reduce the proportion of patients with suboptimal FFR values after PCI by a factor of 11% compared to the control group, and that difference was statistically significant. So across, I suppose, the more clinically proven thresholds, the intervention certainly improved results for those patients. The conclusions from our study essentially would be that there's a large proportion of patients, up to 68% in our findings, who don't achieve optimal post-PCI FFR results after routine standard of care stenting. Concerningly, of those, approximately, in fact, 30% almost of patients don't even cross the guideline-directed revascularization threshold of 0.80 and are left with persistently truly suboptimal FFR results after a stent. What we found was that by applying a routine post-PCI assessment and optimization protocol, we were able to significantly increase both the FFR and the coronary flow reserve in the patients who had optimization measures applied. And we found that while we didn't significantly increase the proportion with optimal values of above 0.90, we did significantly reduce those with suboptimal values less than 0.8. I think it's an interesting field, the post-PCI optimization. I think really what the study lacked was power, and we know that. Certainly it had no power for clinical outcomes to say that we're building, I suppose, on the work of colleagues previously to say that higher post-PCI FFR values are associated with better outcomes. The key of our key, I suppose, goal of our study was to demonstrate that if you look for suboptimal disease, you will find it in significant proportions amongst your patients, and that applying optimization measures in a protocolized fashion can improve FFR and coronary flow reserve results for these patients. So I think the next step would be to organize larger multi-center trials and see if we can show that, yes, there is the optimization measures after stenting would be a means to improve patient outcomes.